గుడ్ మార్నింగ్
సార్. గుడ్ మార్నింగ్ సతీష్ గారు.
ఈ మధ్య కానుకుంటున్నావు ఏంటి?
లేదు, మాది NABH నిన్నటితో అయిపోయింది. అది కొంచెం బిజీగా ఉన్నాను. అది 5th ఎడిషన్ ఫస్ట్ టైం మాది. కొంచెం కష్టమైంది అది.
అలాగా.
మీది ఎన్ని బెడెడ్ చూపిస్తున్నా సార్?
మాది 150 బెడెడ్ చూపిస్తున్నాం సార్.
అబౌట్ 200 బెడ్స్ ఉంటాయి కదా, కొద్దిగా రిస్క్.
ఏం లేదు సార్, అన్ని అలా అంటే 5th ఎడిషన్ బాగా అంటే 4 బ్లాక్స్ లో ఇచ్చాడు. 5th ఎడిషన్ ఎక్సలెన్స్ అయితే చాలా కష్టంగా ఉంది. 5th ఎడిషన్ లో ఎక్సలెన్స్ ఆడిట్ ఈజ్ వెరీ టఫ్. అంటే అన్నిటికీ కూడా ప్రాసెస్, ప్రతి చిన్న పనికి ప్రాసెస్ చూపించమంటున్నారు. మేము చేస్తున్నాం అంటే కుదరట్లేదు. ప్రతిదీ ప్రాసెస్ ప్రాసెస్ ప్రాసెస్. మీ పాలసీ ఏంటి? ప్రతి దానికి పాలసీ అంటే మీ పాలసీ చూపించమంట. మేము చేస్తున్నాం అంటే చాలదంట, చేసినట్టు చూపిస్తే చాలదంట, పాలసీ చూపించాలండి.
పాలసీ ఎలాగా? దానికి ఏమన్నా ఒక ప్రొసీజర్?
ఇప్పుడు సపోజ్ ఇప్పుడు వార్డ్ లో బ్యాడ్ అయ్యాడు అనుకో ఒక పేషెంట్. పేషెంట్ ఏం చేస్తే మెట్కాల్ రేజ్ చేస్తాం, MICU టీం వెళ్తారు, చూస్తారు, అవసరమైతే MICU షిఫ్ట్ చేసుకుంటారు. ఇది జరుగుతున్నది. దానికి ఆల్రెడీ మెట్ రిజిస్టర్ ఉంది, అన్ని చూపిస్తున్నాం. కానీ అది మీరు కరెక్ట్ గా చేస్తున్నట్టు సర్విలెన్స్ ఏంటి? హూ ఇస్ ద సర్విలెన్స్ ఆఫీసర్?
ఎవిడెన్స్.
హూ ఇస్ ద సర్విలెన్స్ ఆఫీసర్? ర్యాండమ్ చెక్స్ చేస్తున్నారా? సపోజ్ అక్కడ మళ్ళీ పేషెంట్ గ్రీవెన్స్ ఉండాలంట. పేషెంట్ ఫ్యామిలీ ఏమో ఒప్పుకోలేదు అనుకో, నేను ICUకి రాను అన్నాడు అనుకో, అప్పుడు దానికి లెవెల్ 2 ఎస్కలేషన్ మ్యాట్రిక్స్ ఏంటి? రాత్రిలో ఉంటాడు, ఒక డ్యూటీ డాక్టర్ ఉంటాడు, లేకపోతే నర్స్ ఉంటుంది, అంతే. ఫ్యామిలీ ఏమని ఇంటి దగ్గర ఉంటారు, ఇక్కడేమో అటెండెంట్ ఉంటాడు. సో వాడు బ్యాడ్ అవుతున్నాడు, డీసాచురేట్ అవుతున్నాడు, ICU షిఫ్ట్ చేయాలి. సో డాక్టర్ ICUకి డెసిషన్ తీసుకున్నారు, ప్రైమరీకి ఫోన్ చేశారు, బాగానే ఉంది. ఇప్పుడు వాడేమో రిలక్టెంట్ గా ఉంటాడు. ఉన్నప్పుడు మీ డాక్టర్ బిహేవియర్ సరిగ్గా చేశాడని గ్యారంటీ ఏంటి? మీ డాక్టర్ కూడా కోపం వచ్చి నువ్వు షిఫ్ట్ అయితే బాగుపడతావు, లేకపోతే సస్తావని అలా చెప్పాడు అనుకో, దాని మీద సర్విలెన్స్ ఏంటి? ఆడిట్ చేశారా? ఎన్ని ఆడిట్ చేశారు?
అది ఎలా చేస్తారు?
ఏమో వాళ్ళు పాలసీ. ఇప్పుడు ఏంటంటే MOD సర్విలెన్స్ ఆఫీసరు, నైట్ ఎవడుంటే వాడు సర్విలెన్స్ చేసినట్టు చూపించాలి. ఇది మళ్ళీ ఒక కమిటీ పెట్టి ఎవ్రీ మంత్ డిస్కస్ చేయాలి.
అంటే దానికి ఏమైనా వీడియోలు చూపించాలా ఆడికి? ఇలా ఇలా చేసాం, ఇదిగో ఎవిడెన్స్ అని. అవును చేసేవాళ్ళకి ఏంటి?
చేసిన దానికి రిజిస్టర్ మెయింటైన్ చేయాలి. ఆ రిజిస్టర్ లో వచ్చిన అన్ని ఒక 5 ఈ మంత్ లో 5 మెట్కాల్స్ అనుకో సపోజ్. ఈ 5 మెట్కాల్స్ ని సర్విలెన్స్ చేయాలంట. అంటే మంత్ ఎండింగ్ లో మీటింగ్ పెట్టి, మెట్ కమిటీ మీటింగ్ అని పెట్టి అందులో ఇది నిజమైన మెట్ట.
ఓకే, మీకు మెట్ట అని ఉంటుంది, మాకు ఇప్పుడు కోడ్ బ్లూ ఉంది అనుకోండి. అవి చేస్తున్నాం కదా, అది కాకుండా ఇది మెట్కాల్ గురించి కూడా.
మేము మెట్టను పెట్టాము, ఆల్రెడీ మెట్ట పెడుతున్నాం సార్, ఇది చేస్తున్నాం అంటే.
అవును, సర్వేలెన్స్ ఆడిటింగ్ చూస్తాం ఎవ్రీ మంత్. మెట్ట ఇదేంటిది కోడ్ బ్లూ కమిటీ మీటింగ్ అవుతుంది కదా.
అవునన్నా, కోడ్ బ్లూ గురించి నువ్వు చేస్తున్నావు, ఇప్పుడు దీన్ని చేయట్లేదు కాబట్టి చేయండి అంటారు.
మాకు లేదు మెట్కాలు, సపోజ్ మేమేం చేయాలి మరి?
మెట్ట లేకపోతే మెట్ట ఉండాల్సిందే, యాడ్ చేయాలి మీరు. ఇప్పుడు మీదటి నుంచి మెట్ట రిజిస్టర్ ఉండాలి.
ఇవన్నీ
సార్
దేనికోసం కంపల్సరీ చేయాలి?
దేనికోసం అంటే ఇప్పుడు 5th ఎడిషన్ లో ఇవన్నీ కూడా ఉన్నాయి సార్.
NABH గురించి నువ్వు చెప్పేది?
సారీ, మధ్యలో వచ్చారు,
అందుకే అర్థం లేదు. ఓకే, సరే అయితే థ్యాంక్ యూ.
అదే కొంచెం కష్టంగానే ఉంది 5th ఎడిషన్.
ఓకే సార్, జనాలు వచ్చారు సార్.
ప్లీజ్.
మార్నింగ్ సార్.
మార్నింగ్ సార్. శ్రీనివాస్ సార్.
డేవిడ్ సార్ మొదలు పెట్టండి సార్.
Good morning all of you. Today Dr. Jaideep is going to talk on pulmonary thromboembolism. It's a known topic, but the guidelines are changing, and it is the most deadly complication, and patient needs to identify very fast, and treatment to be started quickly by diagnosing the pulmonary thromboembolism. If you miss the diagnosis, patient will crash rapidly. Dr. Jaideep did MBBS in Andhra Medical College, and he did MD in Jepmar. Now he is working as a consultant in anesthesia and critical care department, Pinnacle Hospital, Visakhapatnam. Now I request Dr. Jaydeep to start the presentation. Jaydeep.
Good morning, everyone. Thank you, sir, for inviting me. Today, I'll be discussing regarding the pulmonary thromboembolism. So, in brief, only it will be, the discussion will be in brief. So, mainly I'll be talking regarding the predisposing factors, the pathophysiology, the diagnosis and the assessment and the treatment of pulmonary thromboembolism. As you know, the pulmonary thromboembolism, which is the most frequent the cardiovascular emergency when it is acute, and is the third most common cause of cardiovascular mortality. And it is a condition which the thrombus or the multiple thrombi usually migrate from the systemic circulation to the pulmonary vasculature. So the blood clots may be arising from the deep veins of the lower and the upper extremities. The DVT and the pulmonary thromboembolism are together considered as the same. They collectively termed as like venous thromboembolism. The incidence usually range from 39 to 115 for 1 lakh for pulmonary embolism, and whereas for DVT it usually range from 50 through 162 per 1000 per 1 lakh population. The 28-day case fatality rate after the first episode of thromboembolism is approximately 11%. So mainly where does this source of thrombi usually arises is the lower extremities, as I said, in more than 80% of cases, 85% of cases, and where the blood flow is more turbulent. So the thrombus arises. So when the thrombus propagation exceeds the rate of thrombus organization, and whereas the detachment from the endothelium, the part or the whole thrombi can break and migrate to the inferior vena cava and enter into the pulmonary capillaries, causing obstruction. It can also arise from the upper extremity thrombosis, which is frequently associated with the CVP cannulas and the intravascular cardiac devices, or the thoracic outlet syndrome, or in a paged shorter syndrome, where it is also called as effort thrombosis, where the primary thrombus will be in the subclavian vein. It is usually seen in the young patients who does a strenuous exercise. Coming to the predisposing factors, as we all know, the triad responsible for the thromboembolism, the Vichos triad, the factors which are the venous stasis, the hypercoagulability, and the injury to the vessel wall. When we come to the reasons behind why the stasis in the blood is the common reasons of the immobility, bed rest, and for a bed rest for more than 3 days, it is also comes out of the stasis. For a prolonged anesthesia, in which the anesthesia for more than 12 hours, and congestive heart failure, the core pulmonary, and the previous history of any venous thrombosis, these comes under the stasis. And the factors contributing to the hypercoagulability, the malignancies, the anti-cardiolipin antibody, nephrotic syndrome, essential thrombocytosis, and the patient wearing estrogen therapy, heparin-induced thrombocytopenia, and inflammatory bowel diseases, the paroxysmal nocturnal hemoglobinuria, and disseminated intravascular coagulation mainly due to seen in the amniotic fluid embolism, on the protein C and S deficiencies, and the antithrombin 3 deficiency. These all contribute to the hypercoagulability. Whereas for the endothelial damage, mainly due to the surgery or the trauma. So in most of the hospitalized patients, they usually have at least one risk factor for the DVT. So some describe as the risk factors based on the transient, persistent, and the inherited risk factors. So coming to the transient risk factors, these without prophylaxis, their venous thrombosis usually occurs in 20% of all major surgical procedures, and with embolism in 1 to 2% of cases, and it is higher in orthopedic procedures in over more than 50%. Whereas the frequency of a fatal postoperative pulmonary embolism usually ranges from 0.1 to 0.4 in elective general surgery procedures, and 1 to 5% in patient undergoing elective hip or knee surgeries, emergency hip surgeries, major trauma, spinal cord injuries, and obesity, the metabolic syndrome, where the metabolic syndrome, like diabetes, hypertension, and the hypercholesterolemia, these comes under the transient risk factors only. So in the trauma unit, the 56% with lower limb fractures or the pelvic fractures had evidence of DVT, whereas 40% with injuries to face, chest, or abdomen had DVT. So other risk factors like the NIHAC classification 3 or 4, congestive heart failure, COPD, sepsis, inflammatory conditions, and recent myocardial infarction, advanced age, these are all comes under transient only. The paralysis, bed rest more than for 3 days, and prolonged air travel. So long distance traveling in the economic class syndrome, which is for a prolonged air travel, it has a 1.5 to 3-fold risk of thromboembolic risk. And the pregnancy is the most common in less than 40 years of age, and it accounts for about 20 to 50% of pregnancy-related deaths. So it's mainly due to the decreased mobility and the pregnancy-related hypercoagulable states. Factors like 2, 7, 8, 10, the protein C resistance and the decreased proteinase levels, and the venous obstruction from the uterine compression. This is the persistent risk factors seen in the malignancies from the lungs, pancreas, brain, ovary, and stomach. So there are multiple factors probably involved. Basically, there will be abnormality in the hemopoietic system related to the malignancy, or all the chemotherapeutic agents, the immobility, infectious complications, as well as the indwelling catheters. Like another hypercoagulability states like polycythemia, essential thrombocytis, and acute promyelocytic leukemia also results in overproduction of different cell lines. They mainly by increased blood viscosity cause thromboembolism and the release of procoagulants. Paroxysmal nocturnal hemoglobin, a rare condition. It is seen in approximately 40%, particularly involving the intraabdominal vessels. And other conditions like antiphospholipid syndrome, it has high risk for recurrent venous thromboembolism, and it has benefit from using of warfarin. So coming to the inherited risk factors, where the abnormal or the functional abnormalities in the coagulation system comes under the inherited risk factors. So the most common will be the FACT5 latent mutation, which is common seen, and the prothrombin gene mutation. 3 other conditions like deficiency in the antithrombin 3, protein C, and DUS also contribute. In this patient, the following inherited risk factors, the lifelong anticoagulation may be necessary. Come to the pathophysiology, mainly the factors determining the size and location where the embolia is located, and with associated with the cardiopulmonary diseases and the secondary humoral mediated response by the body and the vascular hypoxia response. These are the factors and the rate of the resolution of embolia. Mainly once detached from the point of origin, it enters the systemic venous system and the right chambers of heart cause pulmonary arterial obstruction. So mainly the acute pulmonary embolism mainly interfere with the both circulation and gas exchange. Mainly the right ventricular failure is due to the pressure overload, which is the primary cause. The pulmonary artery pressure will be more than 30 to 50% occluded due to the thrombus, thereby causing vasoconstriction by the release of thromboxane and the serotonin. This will cause abrupt increase in the pulmonary vascular resistance, resulting in the increased right ventricular dilatation, causing right ventricular tension. So the myocyte stretch will be increased. So the increase in the contractile time period of right ventricle, and the neurohormonal activation will be there, leading to inotropic and the chronotropic effect. So the right ventricular oxygen demand will be increased. So the prolonged contraction time in the diastole leads to the leftward pushing of intraventricular septum, and there can cause the desynchronicity. On the leftward ventricular pushing impairs finally, and they will lead to decreased cardiac output, causing hypotension and decreased right ventricular coronary perfusion, leading to right ventricular oxygen delivery decrease and leading to cardiogenic shock or death. Coming to the hemodynamic consequences, with pulmonary vascular obstruction less than 20%, there can be modest hemodynamic abnormality. When it exceeds 30 to 40%, there will be increase in the right ventricular pressure, but cardiac output is usually maintained. When the compensatory mechanisms begin to fail, when the obstruction is exceeding the 50 to 60%, the cardiac output begins to fall, and right atrial pressure increases dramatically. The gas exchange abnormalities usually seen are the hypoxemia, which is most common physiological sequence. So the obstruction of the pulmonary artery, it directs the blood to the other parts. So there will be increased shunting, intrapulmonary shunting, and the ventilation perfusion mismatch will be there, and there will be decrease in the mixed venous oxygen level. So the further shunting and valvular discourse will be increased in case of due to alveolar hemorrhage or further atelectasis if it happens. Hypocapnia is due to the hypoxic induced vagal stimulation with resulting hyperventilation. Finally, hypoxemia can lead to increased sympathetic tone, which in turn causes systemic vasoconstriction. So uncommon consequences is the pulmonary infarction, which can be seen. Coming to the classification, how it is classified as massive, submassive, and the non-massive. Massive, it has incidence of less than 5%, and it is defined as the acute pulmonary embolism with hypotension, systolic blood pressure less than 90, or a drop in greater than 40 for longer than 15 minutes. Patient is in obstructive shock or cardiac arrest. These patients have a high mortality rate of more than 25%. Come to the submassive pulmonary embolism with incidence of 20 to 25%. These patients, the systolic blood pressure will be more than 90, and either the right ventricular dysfunction can be there, which can be seen by echo or by the CT guided right ventricular to left ventricular ratio more than 1, and with the positive biomarkers. So if either of it is the right ventricular dysfunction or the positive biomarkers is present, it comes under the intermediate low risk. If both are present, it comes under the intermediate high risk, which has an incidence of 10%. Non-massive, it is a incidence is a 75%, and there is absence of hypertension, right ventricular dysfunction, myocardial necrosis. These patients have a mortality risk of less than 1%. Coming to the risk factors, so the acute pulmonary presentation will be either the dyspnea, sudden onset of dyspnea, and the pleuritic chest pain can be there. Pleuritic chest pain is due to the distal emboli causing the pulmonary infarction, or the typical angina due to the right ventricular ischemia. And also some patients can have presence directly present with circulatory collapse only. So few patients cough in case of DVT, like swelling of the pain, hemoptysis, syncope can be there. So the tachypnea is the most common physical finding which we can see. And the less common are the crepitations, tachycardia, loud S2, and fever are seen. So these are the incidents of signs and symptoms of pulmonary embolism. They were the dyspnea and pleuritic chest pain account for more than 60% in massive and submassive. Coming to the scoring system, which is commonly used, the Well score system and Geneva and the modified Geneva score system. It is used as a assessment of the pretest probability. So the variables commonly used are the DVT symptoms or sign, the pulmonary embolism likely or more likely than the alternative diagnosis, and heart rate more than 100, immobilization, the previous history of DVT, hemoptysis, malignancy. Based on these variables, the appropriate scoring is given, and the total score is less than 2. It considers a pretest probability of low, 2 to 6 as a moderate, and more than 6 as high. So if it is less than 4 or equal to 4, the pulmonary embolism is unlikely. If it is more than 4, it is a likely cause. An alternative scoring system which was given is the years criteria, in which the variables are taken from the Well score system only, but in a combination with the D-dimer test, when the presence of hemoptysis and the signs of DVT are there. And the pulmonary embolism has the most likely diagnosis when combined with the D-dimer. As the D-dimer is added, there is need for CT is reduced. It is a revised Geneva score. This patients, the variables used are the elderly, age more than 65, and the previous history of DVT, surgery, previous history of surgery, or the lower limb fractures within 1 month, and patient having active malignancy. Symptoms like unilateral lower limb pain, hemoptysis, and clinical signs like heart rate 75, 94, more than 95. Pain on the lower limb deep in a small patient. Based on these clinical signs and symptoms, malignancy, surgery, and age of DVT, the points are given, and based on this score, the pretest probability is calculated. And if it is less than 3, it comes in as a low, and 4 to 10 the moderate, and more than 11 it is high. So the investigations, come to the investigations. Usually the patients, the laboratory investigations may show a leukocytosis. In the ABG, you can see the hypoxemia with hypocapnia with a normal alveolar to arterial oxygen gradient to increase shunting. And the cardiac biomarkers like troponin, BNP levels can be elevated, which is seen in the submassive pulmonary embolism. So the D-dimer test, which is highly selective, but it's a non-specific. It can be positive in other conditions like advanced age or pregnancy, trauma, infections, post-operative period, and many inflammatory conditions, and also malignancy. So in a Dutch primary care, it was studied, there was a pulmonary embolism could be ruled out in 46% of patients with suspected pulmonary embolism. It was without proceeding to the imaging test, but it has a failure rate of 1.5%. So the next investigation is the ECG, which is the specific one is the S1Q3 T3 pattern. It's commonly seen. And there can be right ventral branch block or TV inversions in the anterior leads like V1 to V3. And the right ventricular strain pattern is usually seen, which includes the right axis deviation, suggesting the right ventricular hypertrophy. These are just radiographic findings which are non-specific, like Hampton's hump, which is dome-shaped pleural-based opacification seen in the lung, and the Westermarck sign, the peripheral oligemia, which is seen. So mostly the pulmonary embolism, there can be a normal chest X-ray too, with unexplained acute dyspnea or hypoxemia and the tachypnea. This is a sign of Westermarck sign. Coming to the CT, CTB is the first line imaging in the pulmonary embolism. It is a confirmatory and excluding embolism with lower intermediate likelihood of disease, and confirming embolism with the intermediate or high probability of disease. In a prospective, in a PIOPED-2 trial study, which used the 4 multidimensional CT technology, they demonstrated that the sensitivity is high. Pulmonary embolism is 83% and the specificity of 96%. Positive predictive value of 86 and negative predictive value of 97%. So in this patients, the ratio of right ventricle to left ventricle short axis diameter is calculated, and if it is more than 1 on the initial CT finding, it is a predictor of a 3-month mortality, and it is used for the non-specific pulmonary embolism. So other findings that convey the right ventricular dysfunctions, like if the contrast is entering into the inferior vena cava, and with the associated intraventricular septum flattening, which can be independently correlated to the adverse outcome in acute pulmonary embolism. Due to its ease of availability and maybe overutilized in outpatients without adequate patient screening through validated methods such as well score or the pulmonary embolism rule out criteria. So it has a main advantages over the pulmonary ventilation perfusion scan. It has more diagnostic results with few indeterminate or inadequate studies and the detection of other diagnoses like pulmonary pneumothorax or any other conditions. So this is a picture showing the right ventricular to left ventricular ratio of more than 1 and the flattening of interventricular septum. So the CTPA is the main strength of the it is readily available, and it has excellent accuracy and a strong validation in prospective management, low rate of inconclusive results, whereas the limitations include the radiation exposure to the iodine contrast. It has limited use in the iodine allergen hyperthyroidism and risks in pregnant and breastfeeding women. It is contraindicated in severe renal failure patients. Coming to the echocardiogram, the patients who are having an unexplained right ventricular volume of the pressure overload should suggest the possibility. So the trans-esophageal echocardiogram has a better sensitivity and specificity for central thrombus, that is proximal thrombus or emboli. So the 4 parameters are independently associated with mortality. The ratio of right ventricular to left ventricular end diastolic diameter, the right ventricular systolic pressure, the tricuspid angular plane systolic exertion, and the inferior vena cava collapsibility. Based on these parameters, it is associated with the mortality. These are the dramatic pictures, so like showing like echocardiographic changes. In the picture here, there is enlarged right ventricle in the parietal long axis view, whereas in the B, the dilated right ventricle, which is seen in the post-chambered view, with the basal right ventricle to left ventricle ratio more than 1, and the McConnell sign can be seen. McConnell sign is something but the free left ventricular, free right ventricular free akinesis will be there, with the flattening of interventricular septum and normal apex can be seen. Whereas the intraventricular septum also it is flattened, which is seen in the parasternal short axis view. The IVC also will be distended with the diminished inspiratory collapsibility. The 60/60 sign, which is seen in a Doppler, which is a coexistence of acceleration time of pulmonary ejection less than 60 milliseconds, and mid-systolic notch with a mildly elevated peak systolic gradient at the tricuspid valve seen. So few patients can have a right directly thrombus in the right ventricle. And the tricuspid annular plane systolic excursion in the M mode will be decreased. The tricuspid annulus velocity will also be decreased in the Doppler. Coming to the ventilation perfusion scanning, it provides the valuable information if used and interpreted appropriately. Negative studies capable of ruling out pulmonary embolism. Positive predictive value of high probability can be seen by seeing the multiple segmented size mismatch defects, usually indicated in case of renal failure patients, iodine contrast allergy, pregnancy, and critically ill patients. Duplex ultrasound, which is commonly used for the OPD basis, there is combination of it's a Doppler venous flow detection and real-time B-mode imaging. This is investigation of choice for diagnosing venous thrombosis. It is a non-invasive best method for OPD procedures. A number of criteria are used to diagnose the venous thrombosis. The most relevant, which is the non-compressibility of a venous segment. Secondly, the less reliable will be the presence of echogenic material within the venous lumen and venous distension and the loss of phasicity. And the response to the Valsalva and the augmentation of spontaneous flow can be seen. Coming to the conventional pulmonary angio, which is gold standard, but it's a highly invasive procedures and has high mortality. Only the Filling defect can be seen and upper cutoff can be seen in the vessel. The filling is usually observed in the fluoroscopy. This is an approach for the pulmonary embolism patients. Patients who are suspecting intermediate or high clinical probability of pulmonary embolism, so we have to check whether the patient is hemodynamically stable or unstable. Patient is hemodynamically stable, consider doing a CTPA. And if pulmonary embolism is confirmed, stratify the risk by using CTPA, blood test, and the echocardiography. If the segmental or subsegmental pulmonary embolism and with a normal cardiac biomarkers, then anticoagulation only is the primary treatment. Whereas by the echocardiography, if it is the right ventricular to left ventricular ratio is increased and there is a proximal clot with the increased cardiac biomarkers, echo can be done to assess the RV function and perform a thrombolytic embolytic and anticoagulation therapy. If it is hemodynamically unstable, the echo showing the pulmonary embolism in the right ventricle or the pulmonary embolism, directly go with the thrombolysis. Coming to the risk scores, which are commonly used to predict the mortality, the simplest one is the simplified pulmonary embolism severity index. If one of the clinical features is present, it is considered as an high risk, that is a 30-day mortality risk. The age is more than 8 years and history of any malignancy, chronic cardiopulmonary disease, and heart rate more than 110, systolic blood pressure less than 100, and arterial oxygen saturation less than 90. So each point, 1 point is given to each clinical feature. So the main goals for pulmonary embolism are to ensure adequate oxygenation, provide hemodynamic support to prevent the thrombus propagation and embolic recurrence. Many non-massive patients can be safely discharged at home to continue the anticoagulation therapy. Either by the HTS score or the simplified pulmonary embolism severity index score, it can be used to identify these patients. The HTS scores includes whether the patient is hemodynamically unstable or requiring a thrombolysis or the embolectomy, or active bleeding is present or high risk of bleeding, or the patient who oxygen supply is required to maintain a saturation more than 24 hours, and for pulmonary embolism diagnosed during anticoagulation treatment, or else in severe pain needing IV medications, pain medication for more than 24 hours. So treatment in the acute phase, so the patient usually the hemodynamic and respiratory support is the main management for main initial management. So patients who are unstable, mechanical ventilation, and who are stable can be NIV or HFNC can be preferred. And these patients have a refractory hypoxemia, so there can be a fall in the saturation levels. Refractory hypoxemia due to the ventilation perfusion mismatch. So right ventricular failure can be aggravated by increased intrathoracic pressure after intubation or keeping on a positive pressure ventilation. So less tidal volume of less than 60 ml per kg, and PEEP should be kept as a cautious. So the pharmacological treatment of acute right ventricular failure is you have to assess the CVP by means of checking the IVC if the collapsibility is there, and if it is low, the CVP, if it is low, then the moderate fluid challenge can be used, less than 500 ml, to increase the cardiac index in patients with the acute pulmonary embolism. But careful regarding the volume loading, it has a potential to overdistend the right ventricle also and can cause a reduction in the systemic cardiac output. So use of vasopressors is necessary. In parallel, we have to discuss with the pharmacological, surgical, or the interventional reperfusion treatment. So noradrenaline, which can improve the systemic hemodynamics by bringing out an improvement in the ventricular systolic contraction and coronary perfusion pressure without causing a change in the pulmonary vascular resistance. So the cardiac index may aggravate the ventilation perfusion mismatch by further redistribution of blood flow from obstructed to the unobstructed version. This is a strategy used, the volume optimization, which I explained now. So the mingle acted of less than 500 ml over the 15 to 30 minutes has to be given after checking the IVC when it is the CVP is low. So the vasopressors, norepinephrine, to increase right ventricular inotropy and systemic blood pressure to promote the positive ventricular interactions and restoring the coronary perfusion gradient. Dopamine also can be used to increase the right ventricular inotropy and lowers the filling pressures. May aggravate the arterial hypertension if used alone without a vasopressor. Other ECMO can be also used, which is a rapid short-term support to it combined with oxygenator. But it has a complications when used on a prolonged longer periods, more than 5 days. The like bleeding and infections can be there. So there is no clinical benefit unless it is combined with the surgical embolectomy. Coming to the thrombolysis, thrombolytic drugs which cause the direct lysis of thrombus by increasing the plasmin production, the plasminogen activation. Thrombolytic agents commonly available as streptokinase, aldokinase, urokinase, tenetiplase also. The indications are the pulmonary embolism with the hemodynamic instability, patients who develop hemodynamic compromise during the conventional therapy with heparin, and the patients who are having intracavitary right heart thrombi. These are the indications. Absolute indications will be high PTE and presence of hypertension. Possible indications like intermediate risk pulmonary thromboembolism, presence of severe hypoxemia, less proved otherwise, severe or worsening right ventricular dysfunction. Patients with acute pulmonary embolism who appear to be decompensating, like a elevation of biomarkers and tachycardia. And if there is a free floating thrombus which is identified by echo in the right atrial ventricle and extensive clot burden. These are the thrombolytic regimens that it use. Aldoplase 100 milligrams infusion over 2 hours. Acceleration regimen of 0.6 milligrams per kg bolus over 10 minutes. Streptokinase, the classical regimen is 2,50,000 units by international units, bolus over 30 minutes, followed by 1 lakh international units over 12 to 24 hours. The accelerated regimen will be 1.5 million international units over 2 hours. Whereas for urokinase, the classic regimen is 4,400 international units per kg bolus, followed by 4,400 international units per kg per hour infusion over 12 to 24 hours. The accelerated regimen will be 3 million international units infusion over 2 hours. Whereas for retiplase, 2 bolus of 10 units given 30 minutes apart. The tenetiplase, it is based on the weight. The weight based given as a bolus over 5 seconds. For less than 60 kg, 30 milligrams. For more than 60 to less than 70, 35, and more than 70 to less than 80 kg, 40 milligrams. For more than 80 to less than 90 kg, 40 milligrams, and more than 90 kg, 50 milligrams. So these are the contraindications of thrombolysis in acute thromboembolism. The absent will be the history of any intracranial hemorrhage, known cerebrovascular lesion, and the known malignant intracranial neoplasm and or ischemic stroke within the 3 months. And if there is an active bleeding from any source, and significant closed head trauma or facial trauma within 3 months. The related contraindications like severe uncontrolled hypertension on presentation, history of ischemic stroke more than 3 months before, the major surgery less than 3 weeks before, and recent internal bleeding, non-compressive vascular punctures, and the current use of an anticoagulant that produces an elevated INR of more than 1.7 or a PTA more than 15 seconds. And in case of pregnancy, recent invasive procedures, active peptic ulcers, pericarditis, and age more than 70 years, and diabetic retinopathy. These all come under the relative contraindications. So in a trial conducted without trial, these patients, the 1,006 patients with intermediate risk pulmonary embolism were randomized. They are randomized into either tenetiplase with heparin or placebo with heparin. In this study, they met like a primary endpoint. They met by reducing the combined rate of death and hemodynamic collapse. But there is increased risk of hemorrhage in case of tenetiplase, and in case of risk of hemorrhage and also stroke. This improvement in combined endpoint was driven not by the improvement in mortality, but the reduction in the hemodynamic decompensation. This data will provide that the majority of submassive intermediate high-risk patients will do well with anticoagulation alone rather than not requiring thrombolysis in all cases. But they require a careful monitoring for retardation. Coming to the interventional radiological techniques, interventional thrombus fragmentation represents a potential alternative to systemic thrombolysis or surgical embolectomy. The devices use either a pressurized saline or a rotating impeller to fragment the central thrombi. The fragments are aspirated through a separate port on the catheter and allowed to migrate distally. So most of these are safe, effective, and life-saving for central and acute clots. The major recent advance in the catheter therapy is the emergence of surgical embolectomy and the mechanical embolic thrombectomy catheters are used. There are so many FDA approved devices also now available, which avoiding thrombolytics and have a risk of bleeding complications than catheter-directed thrombolysis. So flow traverse suction embolectomy catheter shows a improvement in right ventricular to left ventricular ratio were seen in a FLAIR study compared to those from the catheter-directed thrombolysis. But there are few bleeding events also and short median length of stay. In extract B study with the aspiration system from penumbra achieved a significant reduction in the right ventricular to left ventricular ratio at 48 hours with similar low rates of bleeding complications. At the extract B study with the aspiration system with penumbra. So other options like mechanical thrombectomy, including the Amplatz thrombectomy catheter and angiojet catheter. This is the angiojet catheter which was used, the centrifugation pump console, the filter syringe bag, and angiovac cannula is used mainly to proprietary mechanisms to fragment the embolic material and then create a vacuum to aspirate it. Coming to the anticoagulants, heparin reduces the thrombus propagation and prevent the embolic recurrence also. So we have IV or subcutaneous low molecular heparin, which is commonly used. So fractional heparin, it is given at an initial dose of 80 units per kg, followed by the continuous infusion at a dose of 18 units per kg per hour. Though it is adjusted, drip is adjusted 6 hours after the initial bolus dose and then 6 hours after each dose adjustment to maintain the APTT ratio of 1.5 to 2.5. So the main advantages of fractional heparin are it can be given as a bolus and also to rapidly achieve a therapeutic window. And the patients who require a thrombolysis also or bleeding complications can be rapidly used. So indications are like renal insufficiency, extreme body weight, and hypertensive crisis. And the circumstances in which the rapid adjustment of anticoagulation is needed, the woman in the last stage of pregnancy who requires a cesarean section, and patients with recent surgery or recent history of bleeding, and the patient who are hemodynamically unstable who needs a surgical procedure such as emergency embolectomy. These are the advantages of a low molecular weight. It has a longer half-life and has the ability to consistently achieve early therapeutic anticoagulation. It has no need for monitoring of anticoagulation effects, and it also reduces the incidence of major bleeding complications. The therapeutic target for peak anti-10A levels range from 0.6 to 1 international units per ml. It was measured 4 hours after administration. The target range for peak anti-10A levels with once daily experience more than 1, whereas it is more than 0.85 international units per ml with tinzaparin and 1.3 international units for natroparin and 1.05 international units per ml with dalteparin. So these are the long-term anticoagulation therapy direct oral anticoagulants which are used. So apixaban, rivaroxaban, edoxaban, and comes under the factor Xa inhibitors. There is a dabigatran, which is the direct thrombin inhibitor. Apixaban, which has a dosing of 10 milligrams BD for 7 days, and then it is reduced to 5 milligrams BD. The parental therapy required at initiation is not required. For the extended therapy dosing is it has an option to reduce to 2.5 milligrams BD. There is a study name like Amplify study. It has a venous thromboembolism recurrence rate of 2.3% only. And with these direct Xa inhibitors, almost the if the creatinine clearance is less than 15 ml per minute, it is avoided. Coming to the rivaroxaban, it is the dosing will be the 15 milligrams BD for 21 days and then 20 milligrams daily. It has no parental therapy at initiation. So extended therapy dosing after the initial 6 months of therapy, it is an option to reduce to 10 milligrams daily. And in Einstein pulmonary embolism study, the VT recurrence rate is 2.1%, whereas for major bleeding rate is 1.1%. The edoxaban, which is a factor Xa inhibitor, it is the dosing is 60 milligrams daily is used. So for parental therapy, 5 to 10 days of parental therapy is used. In a study name called as a Hokusai study, the venous thromboembolism recurrence rate is 3.2%, whereas for major bleeding rate is 8.5%. The direct thrombin inhibitor, dabigatran, which is the The dose frequently given is 150 milligrams median given, and the parenteral therapy required at initiation is 5 to 10 days parenteral therapy, and venous thromboembolism recurrence rate is 2.5% in a study conducted by recovered, and the major bleeding rate is 1.6%. It is also avoided if the creatinine clearance is less than 30 ml per minute, and it is also avoided in if there is a dyspepsia or GA symptoms are present. Coming to the vena cavity filters, it is usually indicated in when there is a contraindication to the anticoagulation. Recurrent venous thromboembolism while on adequate anticoagulation it is also indicated. So it has many life-saving benefits, but the side effect is the venous thromboembolism for normal. So how it is prevented is by using the retrievable filters that are commonly used. So in a study conducted, PREPIC study, it has a study to determine the role of retrievable IVC filters. In this study, the patients who are having the deep or superficial venous thrombosis were included with risk factors like age more than 75, heart failure, respiratory insufficiency, and malignant patients or right ventricular myocardial injury, recent stroke, or with a recent stroke with leg paralysis or bilateral deep in or iliacaval thrombosis. The majority of the patients were included based on the age or comorbidity rather than a high risk group of right ventricular dysfunction or more personal DVT. So what they concluded is that the deployment of a retrievable IVC filter did not risk the risk of recurrent pulmonary embolism when it is compared with the anticoagulation alone. So other embolic diseases will be the air embolism due to various invasive medical problems like the CVP catheters or the launch for IV cannulas and kick in high PEEP and trauma. Clinical features will be altered sensorium, chest pain, dyspnea can be there. There will be interference with the nutrition supply to the affected organ, causing diffuse microthrombi and thrombocytopenia anywhere. Treatment will be the removal of air to the CVP or the direct needle aspiration, and also by 100% hyperbaric oxygen therapy. Fat embolism, which is commonly seen in the orthopedic patients, the neutral fat entering into systemic and cause dyspnea, hypoxemia, petechiae, and neurological manifestations. The main predisposing factors are the traumatic factors of the long bones, like femoral tibia, and the orthopedic procedures, liposuction and lipoinjection, onset 24 to 72 hours after the insult. The GERDS criteria, which is more commonly used, the major criteria including the confusion, petechiae, and the respiratory distress. So the mechanism of injury is vascular obstruction by the neutral fat particles and injurious effect of the free fatty acids. Come to the amniotic fluid embolism, which is a catastrophic during the pregnancy. It has an incidence of 2 lakh leading to the maternal mortality. It usually occurs within the during the delivery or within the 48 hours after delivery. The mechanism of injury is DIC. With the septic embolism, these risk factors include IV drug abusers or IV cannulas, the complication of septic abortions or the septic thrombophlebitis, and these patients have a chest X-ray like a scattered pulmonary inflammation that undergo cavitation, fever, dyspnea, pleuritic chest pain, and hemoptysis are the clinical features. Tumor embolism, it's seen with the malignancy like breast cancer, lung cancer, prostate, stomach, and the liver. There can be a sudden onset of progressive dyspnea, tachycardia, tachypnea can be that. Signs like raised JVP from B2 and S3 due to pulmonary hypertension. So these are my references. Thank you.
Thank you, Jaideep. Very good talk, and nicely covered everything, including the fat embolism, amniotic fluid embolism, everything. Talked like an experienced speaker.
No, sir.
The first class. Any questions?
Regarding the thrombolysis, the weight is it the ideal body weight or actual body weight, you said, sir?
It is the ideal body weight, sir, which is used.
Thank you.
Like for 1080 place only, we are telling you, sir.
Yes.
Yes.
In a cardiac arrest, means acute PA, severe massive PA with cardiac arrest, cardiogenic shock, associated with cardiac arrest. Which is the best thrombolytic agent?
Either tenetoclax. Sorry. Streptokinase can be used, sir. It's the best.
Streptokinase also.
Alti-
Hello?
Altipace.
Yeah, altiplase, actually the problem with altiplase will be given within 15 minutes, first 50 milligrams half dose. Next 50 milligrams should be given in 1 hour. So in a patient in cardiac arrest undergoing CPR, is it possible?
Full dose.
Yana?
Give full dose.
Full dose bolus,
Yes.
altiplase ke.
Yes.
But are there any studies?
పంపిస్తాను నేను.
Okay.
చెప్పలేను.
What about tenecteplase?
Tenecteplase can be given.
Actually, good morning. Tenecteplase is single bolus dose only, but altiplase is
Infusion.
first 10% is bolus, and then I think
But he said it is also bolus. Studies are there. He said he will send.
maybe latest. I don't know that. For the
No. My intention is no. It is only why we are giving is a bolus and followed by maintenance doses. It like one thing is to decrease the complications, and it takes some time to lyse the clot. But thing is, if it is life-saving situation, ideally studied is altiplase only. Tenecteplase in extended support regarding thrombolysis with tenecta. But in a situation with cardiac arrest, give full dose.
No, studies పంపించండి. Any questions?
I think Chatan can share his
ఏంటన్నా?
Dr. Chatan can share his experience recently.
Okay.
Chatan.
Hello? Chatan is there?
Yes. You said. Banu is there? Banu?
Good morning, sir. Dr. Dave, sir, you have experienced one case, no? Please explain that one.
Yeah, I have 2-3 cases experience. One case patient is on table undergoing ready to undergo femur surgery. After spinal anesthesia, patient is preparing for surgery. At the end of means the surgeon is ready to put the knife. That patient developed bradycardia and unresponsive, and there is no pulse identified by the technician. They started CPR immediately, and they called me. Immediately I rushed to the patient. CPR is going on. I thought it is a high spinal or total spinal. Then immediately intubated the patient. CPR continuing until everything is given as per protocol. But 20 minutes over, 15-20 minutes over, there is no response. Rhythm is coming and ROSC, and immediately it is losing. And then I brought the echo machine and put the probe. RV is fully dilated, which is compressing the LV. Then I thought it must be a pulmonary thromboembolism because the orthopedic case, patient stayed on bed rest for 5 days. And immediately we brought the tenecteplase, but by the time we used to give tenecteplase, it was more than half an hour. And Dr. Mohan sir also is there with that case. Means he came once I informed. So after giving the tenecteplase, within 2 minutes, patient ROSC got and stabilized hemodynamically, and then ventilated. Next day morning, patient extubated. Then later, after 1 day, 24 hours, when patient is stable, then we did a pulmonary CTPA, and it shows pulmonary embolism. Because when thrombus is dissolved, and it shows the segmental part of thromboembolism.
Hello.
This is my experience, and another case also. Young man, 21 years, came to casualty, gasping state. So same. When you put the probe, RV is fully dilated and another few cases, like another 2 cases, the same type of patient came in severe breathlessness and gasping followed by cardiac arrest. We thrombolized, same RV is fully distended, but the another 2 cases we could not save. And we did a pulmonary CTPA and there is no PE in the another 2 cases. But RV is fully distended, dilated, compressing the LV. But in case of because of the patient hemodynamical unstable in shock, not responding, we have given the thrombolysis for benefit of because there is no other option.
Sir, how
So
reliable is echo, sir, with respect to diagnosing pulmonary thromboembolism? Because even primary pH and all, RV dysfunction might be there, no, sir?
Yes, correct. It is may not 100% reliable. Maybe sensitivity is around 50% only. In a dying situation, yeah, hello? Yeah, in a dying situation, patient in shock, not responding, impending cardiac arrest, RV is not able to shift the patient to CTPA, pulmonary angiography. RV is fully distended and patient had shock, refractory shock. We don't have another option to identify the non-pulmonary thromboembolism. Maybe it is, as you said, it might be severe PAH with RV dysfunction, RV failure. In that case, patient may not respond and he may bleed also. It may happen. But anyway, patient is going to die. We are not going to save him without doing a thrombolysis. That's why 2 cases survived, 2 cases died. So no guarantee for this.
Thank you, sir.
Any experience?
Yes, sir. Actually, nice presentation, Jaydeep. Last month we had we have seen 2 cases of pulmonary embolism. But actually, they shifted here, and both are neurosurgical cases. So one case is intraventricular hemorrhage. They did EVD. Post-operatively, patient developed fever, so they suspected meningitis. So for that way, they treated. So everything is settled down. Counts are normal. Everything. Still, patient having a continuous fever. To evaluate that, we did other non-infectious causes of the fever. So in that, we did lower limb color Doppler. In this, DVT came positive. Then we did the CTPA. So both patients actually presented with only fever only, and mild tachypnea and mild hypoxemia. There is no hemodynamic instability, and 2D was normal. So in the both cases, CTPA came positive for pulmonary embolism.
For fever.
Oh, fever.
Yeah.
TCT normal, TC count normal. So
Patient
maybe.
is
Is it at the segmental level, sir?
Shankar. Sorry.
Sir, is it at the segmental level or at what level this pulmonary embolism?
Segmental level, sir. Segmental level. Interesting. So we started clicks and therapeutic dose. Never had a severe hypoxemia or hypotension for the both the patients.
Okay.
Only fever.
Only fever. So we have a big argument with the neurosurgeon, neurophysician for us. We are telling that something in the brain is, it means generally post-operative patient we suspect meningitis. Though actually those people only insisted you search for the other causes of fever, not brain. So in that way also we have to keep in mind the pulmonary embolism can be presented.
Of unknown origin we have.
But CSF analysis or anything is done, sir, for
Initially it was positive that for that he received appropriate antibiotics. After that, counts came down and improved, but he has a persistent fever.
One more case of post renal transplant. We thought it's a PE, but it has become a tension hemotherapy.
Is this pulmonary embolism because of the post-operative bedridden and all these causes? Hello?
Yes, sir. Yes, sir.
Femoral thrombus కూడా అనిపించింది.
Satish wants to talk.
Yeah.
Yeah, tell.
Well, last week we have a patient admitted in the floors, recent history of varicose vein surgery, admitted for mild breathlessness. X-ray was normal, ABG was normal, ECG and 2D course seems to be normal. So actually patient creatinine is little bit more, like around 3.2 odd. So admitted with abdominal pain and mild SOB. Ultrasound is showing some gallstones. So got admitted under gastroenterologist. Then physician has seen, the nephrologist seen, pulmonologist seen. And they are treating it as like a liver related infection, and that is the reason for the abdominal pain. And surgical team deferred because creatinine is elevated. They want a CT abdomen. Contrast could not be given, conservatively managed. Patient X-ray, and 4 days after, patient is not improving. Then pulmonologist wanted to rule out a DVT because she is not mobilized for the last 2 weeks post-operatively. DVT is positive. Okay, so then they treated her with fragmin control dose with as per the creatinine clearance. One night, and when I was in night duty, patient became bad and desaturation. Cardiologist wanted that it's an extension to like a DVT. They wanted a CT. CT also done prior to this, and it is showing partial thrombus in the main pulmonary artery, for which the fragment is continued, and patient became breathless now, and there everybody is to. It is all because of the worsening of the pulmonary thromboembolism. We have to thrombolize. So I deferred with that, and I wanted to check an X-ray. I wanted to repeat 2D echo, and 2D echo, no significant change when compared to the past 2D echo. Well, it was done 1 week back. X-ray is completely whiteout X-ray, which is different from the first. So I am more towards the parenchymal lesion rather than a worsening of the pulmonary embolism. So we deferred thrombolysis. I strongly did not allow the cardiologist to thrombolize, and we continued BiPAP therapy because patient is hemodynamically stable. Oxygenation is correctable with NAV. With NAV 60%, she is getting 100% saturation. X-ray is at least left upper quadrant is normal. Rest of the quadrants are completely white out. I thought it is something like secondary ARDS or something going on, or pulmonary edema. No point in thrombolizing this patient. Within 24 hours, patient improved. Patient became normal. Continued the fragment control dose. And I think this is a point why I'm telling this is all PEs on worsening need not require pulmonary thromboembolism unless there is a definitive evidence. Like class 1 indications are floating thrombus in the RV, refractory hypotension, refractory hypoxemia, imminent cardiac arrest, and soft indication is worsening of the RV dysfunction. If these are not there, there is no point in thrombolizing.
In your case, is there any RV dysfunction or hemodynamical instability?
No, that's what I'm telling. No change in the BP. No change in the BP. The repeat 2D echo on the spot is as similar as it was done 1 week back.
Yeah. If you thrombolize this patient may deteriorate very fast. No? He may bleed and.
Yeah. But cardiologist wants to thrombolize.
Yes.
Sir, DVT actually, there is no role of checking a DVT for the patient who is suspected strongly the pulmonary embolism. ఎందుకంటే మన డైరెక్ట్ గా సిటీ యాంజియోగ్రామ్ ఇఫ్ పాసిబుల్ చేసుకుంటే బెటర్ సార్. డివిటి ఉండొచ్చు ఉండకపోవచ్చు.
యా ఉండొచ్చు. ఇట్ విల్ నాట్ రూల్ అవుట్ ద పిఈ కదా.
yes yes yes.
మోహన్ రావు గారు, మీ కేసులో యు హావ్ డన్ దిస్ డి డైమర్. హలో
సార్
D-dimer elevated, sir. D-dimer elevated.
Sir,
D-dimer elevated, you did PA. If D-dimer negative, you need not do CT pulmonary angio.
Yes, yes, sir.
Sir. If your high suspicion is there, D-dimer kindi relation లేదు sir. I think he algorithm. If there is a very high suspicion, don't go for D-dimer. Directly go for a pulmonary angiogram.
High suspicion, yeah. Score is more, no? 3, I think.
then you can go directly for the
All questions Jaydeep can answer kada, David.
Huh?
All questions Jaydeep should answer kada.
అర్థం కాల.
Jaydeep, I want a clarification.
Jaydeep.
Sir, yes, sir.
So, is there
You have to tell.
is there
You have to clarify the questions.
is there any correlation between D-dimer value and intensity of the pulmonary embolism?
Correlation means it is a non-specific finding only, no, sir. It can be able to other conditions also it can be positive. So I have to check whether it is in the post-operative case or surgery, any malignancy. In those conditions also it can be positive.
Yeah.
So it based on the OPD only it can be done, not like all conditions. Ideally, if there is suspicions, we can do a CTPA, sir.
Yeah, the traditional teaching says that D-dimer negativity rules out the pulmonary embolism for strong negative value. That's okay. But thing is, I'm giving you a scenario that one patient D-dimer with high suspicion is 1,000, another D-dimer is 20,000. Is there any correlation between the values and positivity of PE?
Between the values, like D-dimer more than 1,000, they will be turning like it is a positive one, sir.
Yeah, so I think 2018 there is a study is attributed that the higher the value of D-dimer, the higher the probability of PE.
Okay.
It's a background of suspicion.
Okay. Okay, sir.
We have one patient.
Sir,
20 days.
Sir, probability is fine. What about the severity? Does it, is there any relationship between the value of the D-dimer and the severity of the PE? Are there any studies available for that?
Okay.
No, it is only
only
diagnostic value. Prognostication has no value with D-dimer. Prognostication is only done with RV dysfunction, elevated NT-proBNP, high troponin levels at admission has a prognostic value. The worst is high tropi, high NT-proBNP have a negative, more survival is less.
Failure, yes.
Yeah.
Sir, the D-dimer, we have to do different types of D-dimers are there.
Yes,
so
sir.
what is the type of D-dimer we are doing in our lab also is very important.
Correct.
Yes.
So Adi, so the D-dimer kosamu, if you have high suspicion, then directly going for a pulmonary angiogram, then D-dimer positivity and negativity.
Patient is severe renal insufficiency and not fit for but stable but not fit for CT pulmonary angio.
For the stable patient, OPD patient, D-dimer rules out the PT, sir. For unstable patients, it doesn't rules out or rules in.
Unstable means this Monrosar case is stable only, no?
But still it admitted patients ki anta undadu, sir.
Hemodynamically stable.
I think వాళ్ళ మీ algorithm, sorry అండి నేను జయదీప్ గారు నేను చూడలేదు.
అది వన్ వే అంటే వన్ వే సార్ వన్ వే ఆఫ్
ఎట్లా ఉందండి?
అంటే వన్ వే ఆఫ్ శ్రీనివాస్ గారు one way of diagnosing in a stable patients with pulmonary embolism is keeping in mind of risk factors. So actually last month also we had one case came with severe hypoxemia. So CT findings is massive pleural effusion. When we did diagnosis, it is came to adenocarcinoma of lung. So for that patient is only presented with hypoxemia, massive pleural effusion. We thought lung compression causing the hypoxemia. Somehow we with NIV we did the CTPA. CTPA came positive because D-dimer is elevated. So adenocarcinoma means carcinomas are another risk factor for another pulmonary embolism. So these are the stable cases. Also something if you treatment properly, they may improve. They will improve with this antithrombolytics.
Yes, sir. అది జయదీప్ గారు ఒక్కసారి మీ అల్గారిథంలో D-dimer ది చూపిస్తారా ఒకసారి ఏమన్నా?
అది గ్రూప్ లో పెడతా ఉన్నా, టైం లేదు.
ఓకే Sorry.
We'll put
Sir,
in the group.
Thanks.
He will send the PPT.
Thanks, sir.
సార్ ఒకే ఒక్క లాస్ట్ డౌట్ సతీష్ సార్కి. సార్ ఏం లేదు, అది యాక్చువల్లీ ఇన్ పిఈ ద రికమెండెడ్ డోసేజ్ ఇస్ 100 mg ఓవర్ 2 hours కదా సార్ మాసివ్ పిఈలో. అంటే ఐ మీన్ లైక్ ఇందాక కార్డియాక్ అరెస్ట్ డిస్కషన్ వచ్చింది కదా, సో అక్కడ అంటే హౌ బోలస్ మీన్స్ అండ్ ఎంత టైంలో మనం ఇస్తాము, అండ్ ఆల్సో హౌ డు వి కన్ఫర్మ్ అండ్ సినారియో ఎలాగ అంటే దట్ కార్డియాక్ అరెస్ట్ ఈస్ డ్యూ టు పిఈ ఎలోన్ అని ఎలా కంక్లూషన్ రీచ్ అయిన కేసులు సినారియోస్ ఎలా ఉంటాయని సార్? అంతే.
సెకండ్ పార్ట్ ఫస్ట్ ఆన్సర్ చేస్తాను. డయాగ్నోసిస్ 2D ఈకో, అరెస్ట్ విత్ 2D ఈకో, and there is a dilated RERV, and excluding possibilities of arrest like got an APG, hyperkalemia, all these 5H5Ts is not fitting into.
Okay sir. Okay.
And the possibility of like previous history of immobilization, elderly male, something is which is everything is clinically supporting that there is a possible high possibility of this patient is having a PE which led to cardiac arrest.
Okay sir. Okay.
That, and the first part of your question, still I have to prove myself that bolus dose can be given or not, because I read it somewhere. I will send the PPT to you.
Okay sir. Sure. Thanks.
Okay. Time is over. Thank you, Jaydeep. A very nice presentation.
Thank you, sir. Thank you.
Hello.
Thank you.
Thank you, Jaydeep.
Thank you all.
Thank you, sir. Thank you.
We'll close the session. Thank you all for active participation.
Thank you sir. Thank you Jaydeep.
Thank you.
Thank you, sir.
We will close the session.